Hi guys, so today I'm going to talk about neonatal resuscitation. So in approach of neonate resuscitation is very different compared to adult resuscitation. The reason is because in adult, mostly is because of cardiac arrest that is caused by trauma or caused by other underlying heart disease. While in neonate, our main concern is to resuscitate the lung, which are no longer rely on the placenta for gases exchange. And in preparing for resuscitation, we have to anticipate the need for resuscitation in every newborn baby. And before we approach to a resuscitation program, we have to ask obstetrician about 4 questions. First is about whether this is a term baby or a preterm baby because the preparation is different. For example, in preterm, it might require extra equipment like thermal mattress, different size of the tube, and also the mask. Second question is about how many baby is expected, whether it's singleton or multiple pregnancy. But third question is about the characteristic of the amniotic fluid. This is very important because if the amniotic fluid is a post-smelling, not clear amniotic fluid, then we are suspecting chorion amnionicity, which might need a NICU admission for the newborn as well as wash out for neonatal sepsis. And number 4, any additional risk factor for the baby. And after that, we have to make sure that the supply and the equipment is available and further make sure that equipment are functioning. And these are the checklists for before we start the NPR program. And now let's talk about the initial step for newborn baby. So after the baby is born, ask yourself whether this is a term baby for you, whether the tone is good and the baby is breathing and crying. If yes, then we label it as a vigorous term newborn and we can keep the baby with the mother for routine care. Well, when it is not, then we have to resuscitate. First, in the step of resuscitation, we have to put the baby in the place of the radial warmer to keep the baby warm. And secondly, we have to put the baby in a sniffing position, apply slight neck extension, and put it in a neutral position. And please bear in mind that we have to avoid hyperextension or flexion of the neck because this can obstruct the airway. After that, we have to clear the secretion from the airway. And please remember that we have to clear the mouth first before the nose. Remember always end before nose because neonate they are absolute mouth breather. They are absolute nose breather. And after that, we have to dry the baby and stimulate the baby. And after the initial step, how if the baby is still not breathing and the heart rate is still low? Then we have to go for PPV, which is the mainstay of the resuscitation program, and SPO monitoring. I apply a oximeter with sensor. And there's a thing that I would like to highlight is the sensor have to be applied on the right wrist or right hand instead of left hand. This is because we are checking the preductal circulation from the baby, whereby this preductal circulation is mainly supplying your vital organ, which is your brain and the heart. So we are applying on the right wrist or right hand. And we have to make sure that we reach the target of the SpO2. For example, 1 minute, the target SpO2 should be about 60 to 65, 5 minutes about more than 85, and when 10 minutes should be about 90 to 100%. And ECG monitoring to check the heart rate of the baby. And how if the baby got breathing, but the breathing is very mild, shallow, labored breathing with persistent low oxygen saturation? And we have to repeat the procedure of position and clear the airway, SpO2 monitoring, give supplemental oxygen. For example, we can give free flow oxygen by a tubing, which we place the tubing just near the nose and mouth of the baby. And we can also consider CPAP. And now we come to positive pressure ventilation. So this is the most important and effective step in resuscitation. So there are different types of the bag with different way of using. For example, in self-inflating bag, it's like a name of the cell which does not require a compressor gas because it can fill it spontaneously, while flow inflating bag and TP's resuscitator require a gas compressor. And the indication of PPV, when we see the baby is no longer breathing, gasping for air, heart rate less than 100, and oxygen saturation is too low, despite we are giving free flow oxygen and CPAP, then we are going to give this PPV. And the procedure of starting the PPV is we have to choose a correct size of the mask and apply one hand technique when using the mask. And the rate of using this PPV is about 40 to 60 breaths per minute with the inspiratory pressure of 20 to 25 cm, water flow rate of 10 liters per minute. And we set the oxygen blender about 21%. And the person who are giving this PPV have to count the lyric loud to make sure everyone hear. And the lyric that we are using is breath 2, 3, breath 2, 3, breath 2, 3. So when you are saying the breath, you are going to squish the back. Breath 2 and 3 means you can release your hand. Breath 2, 3, breath 2, 3, breath 2, 3, like that. And after that, we have to evaluate the baby response to PPV. By right, the baby will have increased heart rate after 15 seconds of PPV. If there's no, then we have to address the sex-corrected ventilation state, which is the Mr. SOPA. So you guys can read by your own. There are a few reasons that can cause inadequate of ventilation. For example, there's an airway obstruction or there's a leakage from the mask. So after we have corrective state of the ventilation and we give a few minutes of PPV, but the babies still have no clinical improvement with the heart rate still less than 100, then now we have to consider intubate with ETT tube or laryngeal mask. So how do you perform an intubation procedure? Please bear in mind that we have to act quick. This intubation has to be done in 30 seconds. First, we correct the position, insert the laryngoscope, and identify the key landmark. We should be able to see the vocal cord and the epiglottis. So after we identify the landmark, we have to ask another assistant to insert the endotracheal tube and not by ourselves. So after we insert the endotracheal tube, we have to stabilize the tube against the baby palate or the cheek while we are carefully removing the laryngoscope. And we ventilate through the endotracheal tube. And also we have to attach a carbon dioxide detector to make sure that the position of placing the endotracheal tube is correct. So how do you confirm ETT tube is correct in position? So first we can see the carbon dioxide detector. There's a presence of carbon dioxide during exhalation. And thirdly, there's a rapid increase of the heart rate. And there are other methods to confirm as well. You guys can read on. And what if the baby doesn't respond to effective ventilation? Now you have to consider the causes, likely because baby was having very low oxygen saturation and significant acidosis and insufficient blood flow in the coronary artery. And now you have to do a chest compression. So the indication of chest compression is written here, heart rate less than 60 beats per minute, 30 seconds of PPV at least, and evidence by chest moving with ventilation. And the chest compression is very different compared to adult. In neonate, the landmark is different. So we have to identify the area to compress, which is at the sternum here, approximately 1/3 of the anterior-posterior diameter of the chest when we are pressing the baby. And the rate of doing this chest compression is 90 compression per minute. 3 compression with 1 ventilation in every 2 cycles. And it should be done by 2 assistants. One is going to be compression, another one is going to back the baby. So the lyric have to count out loud as well. So we are going to count 1 and 2 and 3 and breath. 1 and 2 and 3 and breath. 1 and 2 and 3 and breath. So when you are counting 1, 2, 3 number, you are compressing the chest with each count. 1 and 2 and 3 and breath. And when you are measuring the end, means you have to release the chest between with each number. 1 and 2 and 3 and breath. Means you are going to give the ventilation when you're saying the breath. 1 and 2 and 3 and breath. 1 and 2 and 3 and breath. Like that. And another thing I would like to highlight is the position of standing when we are doing this chest compression. So this is the correct position when we are doing compression and PPV giving. The reason that we choose to stand at the head of the bed is because this position won't block the people who are going to insert the umbilical cord catheters. Because if we reach the step of giving chest compression, most likely the baby require a IV access from this umbilical cord. So we are not blocking the way of the person. At the same time, this position actually has an advantage to prevent you easily fatigue. Yeah. What if the heart rate still less than 16 beats per minute after chest compression with PPV? Then we have to administer IV epinephrine in every 3 to 5 minutes. If let's say the heart rate is still low, then we have to consider whether this is a hypovolemic shock or pneumothorax case. If it's a hypovolemic shock, then we have to consider to give emergency volume expansion, which is by giving normal saline of 0.9% IV over 5 to 10 minutes. And let's say if you have followed neonatal resuscitation program flow diagram, but the baby still remain 0 ASCA score, how long you should continue? According to the textbook, after 10 minutes of resuscitation, it's reasonable for you to stop resuscitate because there's strong predictor of mortality and serious morbidity. However, the decision is still individualized. It's up to us to decide whether or not to continue the resuscitation. So that's all for me, and I hope you guys can learn something. Thank you.